Hello everyone. Welcome to this instruction course, which is titled Smile, LASIK, PRK or Phakic Lens, Selecting the Best Refractive Procedure for Your Patient. The idea of this procedure is to kind of give an overview of all the refractive procedures that are, refractive options that are available for our patients. And we have an array of stellar speakers. I'm not the chief instructor. He's on his way here. So on his behalf, I'll just get the session started. The first speaker will be none other than Dr. Sri Ganesh. He needs no introduction, one of the leading refractive surgeons, not just of our country, but in the world. And we're all proud of all he's doing. So he's one of the leaders in Smile, and he's going to tell us when to smile and when not to.
If you ask me, I'll say always keep smiling.
Good answer.
And so we'll start off this morning. Good morning, everybody. We'll start it off with a smile. And so this is, can I have my slides up? So the topic is when to smile and when not to. So the whole question is an expensive machine. Now it's about 6 crores. And can I do all refractive errors with smile? I mean, if I invest that kind of a money, do I still need an excimer laser? I mean, if I again have to buy an excimer laser, it's going to cost me a couple of crores more. So what is the smile capable of doing and when can we do it? And of course, smile has a lot of revenue, so I put that emoji up. I am a consultant for Carl Zeiss Meditech. No financial interest in this talk. So let us look at different scenarios for which we can do smile. Then I look at scenarios where we cannot do smile. So this is low myopia, 35-year-old male. You can just see simple myopia, minus 1.5 sphere. Best corrected 6.6. Now a lot of people say that you cannot do smile for low myopia. And the results are not that good. It's better to do a PRK or LASIK. Now why is that? That is because with a very low myopia, your lenticule thickness is quite low. The minimal thickness you can keep the lenticule is 10 microns, which is normally what we keep. But if you have to just treat 1.5 sphere, then you will be about 20 microns. 20 plus 10 is 30 microns, which is a very thin sliver of tissue, which is difficult to dissect and remove. And you can get lenticule tears, you can get lenticule tags. But what this machine is capable of is that you can add tissue. So you can add up to 30 microns of tissue. So in these cases, we add 30 microns of tissue and then it becomes easy to do. And you also have to see that in the central thickness, the minimum is 50 microns between the superficial plane and deep plane. Otherwise, it reflects on the deeper plane when it's making the cut and you can get undulations and then poor quality of vision. So you can get excellent quality of vision with smile for low myopia, provided you know what you're doing, you increase the minimum thickness. And this is the difference map for that patient. You can see that the correction is beautifully centered and you have a good correction. We also published a paper on comparison of smile and PRK for low myopia, and we concluded that both techniques are effective for correction of low myopia. However, smile has superior quality of vision and patient satisfaction because of post-op comfort and lower induction of abrasions at 3 months. The spherical abrasion was lower. This is high myopic astigmatism, minus 10 with minus 1.75 cylinder, and corrected well, uncorrected vision 6.5. If you look at the maps, these are typical cases for smile. You can see the difference map. Centration is excellent, pre-op, post-op, and the difference maps. This is very high myopia. Can we treat very high myopia? Now, smile, you can treat myopia and myopic astigmatism. Now, commercially, you can only treat myopia and myopic astigmatism. Myopia up till 10 diopters, astigmatism up till 5 diopters, and the equivalent is up to 12 diopters. So that is what it is restricted. But we have an open research software because I am a consultant to Zeiss. I do global trials. So I will just share some data with you. This is a 24-year-old female with a pre-op refraction of minus 15 with minus 3.5 SIL. So any of you all see it, you will say, this is only for phakic IOLs. Okay. So we corrected it with smile, and you can see that was a residual refraction. You had some amount, but uncorrected vision of 6-9 parts. I'll show you the maps again. So this is the pre-op map. You can see this. And this is the post-op map. You can see the very well centered, large flattening which is there, and that's the difference map. You can see if you look at the difference in the thickness, it is almost 161 microns. So of tissue, we removed 161 microns of tissue. This patient is stable, doing well. So very high myopia, it is available. We're doing a very high myopia study, but this is something I wanted to share, that yes, you can do it in the future if you invest in the machine. Even higher myopia, this was a 31-year-old female, minus 19 with 5-cylinder. We did a 2-stage bioptics correction. Stage 1 with ICL, she had a residue of minus 1.5 with 3.75 cylinder. We did SMILE for the residual power, and then she had a good correction. These are her maps. Good satisfaction with bioptics. We have published our results with bioptics with SMILE in the Journal of Emetropia, and we find that it's a very good procedure. You can do it 2 to 3 weeks after the ICL implantation. What about high astigmatism? So some of them say that, okay, if you have a pure cylinder, high astigmatism, patient is not suitable for SMILE because it doesn't have a tracker, cyclotorsion, etc. This was a 33-year-old female, pre-op, you can see 0.25 with 4-cylinder, post-op refraction, she has got a very minor half a cylinder, uncorrected vision 6.5. So this is the pre-op map. You can see the high cylinder, and then this is a post-op. You can see that the cornea is very nice now. The cylinder has disappeared. You can see the bow tie here. This is the difference map. This is what is treated, the difference map. So you can treat high astigmatism, but again, you need to compensate manually. You can do a manual cyclotorsion compensation, and this is our paper. This was a landmark paper published in the GRS. We found that the mean cyclotorsion was 5.64 degrees, which is significant. For 10 degrees, you lose 30% of the correction. So if the average is 6, you lose about 15% of your correction. So you get under correction. So if you compensate for it, I'll show you how you do it. It's a safe and feasible technique for high astigmatism. So this is how you compensate for it. After suction, after you applanate, you mark it pre-op 0-180. You have the marks there. You can see that there's a rotation of about 15 degrees. You can hold the cone, bring it into the 0-180 before starting the treatment, and you get excellent corrections. What I've seen is the long-term stability for astigmatic corrections are actually better than LASIK. But the newer machine, the 800, has software for automatic cyclotorsion, which will be available. So with your IOL master, you take the iris image and it automatically compensates for cyclotorsion. So it's not a problem treating high astigmatism. What about mixed astigmatism? This is another question. Mixed astigmatism can be done only by an excimer laser. But we had the open software, so we treated cases, I think 11 eyes we treated with mixed astigmatism, and we have sent it to JRS for publication. I'm just showing you an example. This was a 28-year female, +1 minus 4.25 cylinder, and we did the treatment, and post-op she had an uncorrected vision of 6.5 minus cylinder, but she was not accepting. So this is the maps. This is the pre-op map, and this is the post-op. You can see that the cylinder is corrected very well. That's the difference map. Hyperopia, this is again a 21-year-old female. Hyperopia right now is not commercially available, but it should be available by the end of the year with the 800, VisuMax 800. They are launching the VisuMax 800 on Saturday here, and I'll be talking more about it. But this is a 21-year-old female. We were one of the global sites for the hyperopia trial, 8 centers all over the world. So this is an example from that. You can see that she has got a high hyperopia, 5.5 sphere, 0.75 cylinder, improving to 6.5. Post-op plano with a very small 0.25, uncorrected vision, best corrected 6/6. Okay, and you can see the video of how you can do hyperopia with SMILE. And you have a very large zone. It goes up to 8.8 millimeters, so you have to use a medium cone. It removes more tissue in the periphery and less tissue in the center. Center, it's only about 30 microns. You can see, so it makes a donut-shaped pattern, And so you can treat hyperopia. We have finished the trials. It's being sent for publication. You can see the donut-shaped pattern, and then you dissect it like you dissect for myopic smile and then remove it. I will not go through this for paucity of time, but this is the kind of a pattern for you have the optical zone, which can be 6.3 to 6.7 millimeters. You have a 2 mm transition zone, and then you have a 90-degree lenticule side cut, 8.8 cap cut with 0.25 clearance, 120 micron cap thickness, 30 micron minimal thickness, and you can remove it through a 2 millimeter access incision. So this is the difference map for hyperopia. You can see that this is the pre-op topography. This is the post-op. You can see the central steepening. You can see the beautiful centration. It's centered on the visual axis. This is the difference map. You can see the large zone. The corrections are more stable. The amount of induced aberrations are less than with LASIK. So that, but the kind of results are similar to hyperopic LASIK. What about presbyopia? Yes, you can do mini monovision with smile also, and it works very well with a myopic smile. And the same, this is the pre and post-op whereas like for myopic smile. You can also do monovision with hyperopic smile for presbyopic patient. This is a 46-year-old female, and you can see we aimed for a residual myopia of 1.75, ended up with -2 sphere, very happy 6.6 and 5, right eye dominant. And these are the maps. You can see the hyperopic treatments with the central steepening, both eyes difference. So when not, so now you know that smile can be used for most procedures in the future, maybe in a year or so. But when should you not smile? You need not frown, but when you should not smile. So we look at it. One is if you have ocular surface issues, if you have Bowman's membrane dystrophy, if you have recurrent epithelial erosions, then I would suggest that you do a surface ablation rather than going for a smile or LASIK. Moderate to severe dry eye, again avoid smile. In mild dry eye, smile probably is better than LASIK because the number of nerves, corneal nerves that you're going to cut, the regeneration of the corneal nerves also is better with smile. So smile may be a little better than LASIK if there is mild dry eye, but if moderate to severe dry eye, this is when you avoid, you can go in for a phakic IOL. Corneal scars, if they are significant central denser scars, avoid smile because it is a femto laser and you can have vertical breakthrough in superficial scars, and if the scar is quite dense, then it does not penetrate, then you will have difficulty in dissection. You may not be able to dissect and remove the lenticule. Sometimes you get very thin peripheral scars because of contact lens wearers, contact lens infections. If it's a very thin scar, the laser will still penetrate. I had a case which had a scar which was in the mid, just paracentral area, which was slightly deeper at about 140 microns. So what I did is we kind of designed the lenticule to include the scar, and then we were able to do the smile. That was a unique case, but it was not a very dense scar. Then irregular astigmatism, again you would not like to do smile either because of trauma, scars, corneal surgery, post-refractive surgery, form frustrate keratoconus, and these corneas probably you should look at topoling treatments and you would avoid smile. You cannot do topoling treatments. This is a very fraction of your refractive case, a very small, maybe like 0.2%. Then the other condition is if you have ocular higher order abrasions more than 600 microns, then corneal or ocular wavefront guided treatments are suitable. Smile, you can have correction of spherical abrasion that is coming, it's known as high smile. We are looking at it. Smile itself does not induce a lot of spherical abrasion as compared to LASIK because of you don't have the cosine effect, the sum of so you don't have a reduced ablation in the periphery like an excimer laser. So it induces less spherical abrasion, but you can also kind of adjust that with Malacara annotations, and then you can adjust the amount of spherical abrasions, which may be useful for presbyopic treatments that would be coming, but you can't really do a wavefront guided treatment. So those patients who need wavefront guided treatments, then smile may not be ideal. But again, that's a very small percentage. So these are some of the reasons not to do SMILE. To conclude, SMILE can correct all kinds of refractive errors safely and effectively in the future. Right now, only for myopia and myopic astigmatism. Iris registration automated cyclotorsion will be available on the 800, and you can get better astigmatic outcomes. By next year, it should be available. Wavefront guided SMILE may be possible in the future with a customized lenticule profile being worked on, but it's probably not in the short future. So these are my indications on when to SMILE and not to SMILE. Thank you very much for your attention.
Thanks, Ganesh, for that lovely talk and holding fort while I was not being allowed inside. So,
if there are any questions, then I can.
Yeah, one quick question and then, yeah. So I was wondering, like I bought my SMILE machine like almost 5.5, 6 years back. And when I bought it, I was being told that hyperopia should be available anytime now. And it's been almost 6 years. Yeah, and you've been doing the trials in Nepal, they've done, and everybody's reported excellent results. What's holding back hyperopia? Because we've got almost everything else.
It has
now.
to get the CE approval. So the global results have been submitted to the CE, and it is on the verge of approval, and hopefully they are going to launch it by the end of this year.
And will it come to both the VisuMaxes?
No, it's not going to come on the 500, because on the 500 it takes more than 30 seconds with a higher risk of suction loss. With the 800, it's much faster for myopic SMILE. It's just like 8 seconds. For hyperopic, it would be within 15 seconds. So it would be available only on the VisuMax 800. Plus, on the VisuMax 800, you can correct for angle kappa, which you cannot do on the precisely on the 500. You can kind of center on the visual axis, but here you can exactly measure and compensate for the angle kappa. And for hyperopia, a lot of the hyperops have large angle kappa, and then if you don't treat it exactly on the visual axis, you can have a lot of induced aberrations like coma, which can drop your best corrected vision. So that's why they are not going to give it on the 500. It will be available on the 800. So you'll have to.
A lot of competition for VisuMax now. They're very good machines, all available now. Four new machines available, right?
Yeah. Ours was the first one of the 5 for the global trials, and now I think we have about 4 installed, and they're launching it on Saturday. So it should. We're looking forward to the 800. Thank you very much, Gaurav, for including in my.
Thanks for coming, Shri Ganesh. So I'm really sorry, everyone. Good morning. I was held up outside because my badge seemed to be incorrect and they didn't allow me inside for a time. So I was late. And a very good morning. And so we have this course today, which we've already started off with an excellent talk. And the idea was to decide, with all these gamut of refractive surgery procedures. So we have a stellar faculty and who will be talking on things that they do best. And we have these faculties lined up on the various topics. And I was going to speak on introducing the course and how we choose procedures. We all are aware of how refractive surgeries have evolved over time, and it's been a very exciting journey. It's been a long journey. One might think that it came up only 10, 15, 20 years back, but long back, there were refractive surgeries being done. And today we have access to many different things. We might call it all as LASIK, but frankly, LASIK probably occupies a very small part of what we do in refractive surgery today. FDA approvals have come over the years, and you know that PRK was approved almost for very, very long back, and then LASIK, and then SMILE about 5, 6 years back. And of course, we started doing Phakic ICLs almost 15, 20 years back, but toric ICLs probably became available in the US only this year, or I'm not very sure, but they still weren't available till last year. And then refractive lens exchange, which has always been a difficult topic to discuss for all refractive surgeons, whether to do it or not. And today, I think broadly, these are the procedures which are available to us, and they do, kind of justify that different patients need different procedures, and not one procedure will fit all. So how do you select the right procedure for your patient? I think it all depends a lot also on factors which are sometimes beyond our control. So availability of equipments to your practice, like you might have access only to maybe LASIK, some may have only access to PRK, they may not have invested in a microkeratome. The surgeon's preferences may be different. Some surgeons are sold to doing only SMILE, some are sold to doing only PRK, and some are convinced that Contura vision is the best, and the threshold for doing phakic lens is also very variable between surgeons. So next would be the patient's preferences. Many times you want to offer a procedure to the patient, but the patient has read up on Google and decided he wants a particular procedure, and he may find you based on what procedure he would prefer, and in spite of what he may be actually fit for, you may not be able to offer him the correct procedure for him, and you may actually lose the patient if you try to push him the other way. And also, of course, the patient's parameters. Now, this should be the most important factor to decide, but sometimes it is not. What are the patient's parameters and what are the indications? So equipment availability, again, as I said, it may be a shared facility. You may be living in a town which does not have access, or you may have all the procedures available to you, as in some good top centers. And whether you have an excimer or microkeratome or a femtosecond laser or a Visumax or similar or a different lenticule machine. Now there are almost 4 machines available for making smile-like lenticules. And then, of course, phakic lenses, which actually are available to everyone, but somehow the penetration has not been great, in spite of the fact that they are one of the most useful procedures in refractive surgery and don't require any investment in a machine. And so Dr. Sonu Goel will be trying to talk about this. So I think when it comes to surgeon preferences, as I said, convictions and equipment availability and personal experience play a big role. At what time or stage of this thing did you train, and what all whom you trained under may make a difference, and then what your results do will also make a lot of difference. Industry, of course, keeps trying to push you into different directions, and you have to take a judgment on your own. And then country-specific factors. In Japan, LASIK is not done at all. They kind of banned LASIK because, so it could be depending on which country you live in, that what procedure might work. Or for example, surface procedures in the European, Mediterranean area, they get a lot of haze. So there are so many preferences which may happen because of regional specific preferences as well. And as I said, patient preferences, their expectations from the procedure, their occupation, their interests. Of course, when Google educates patients, and much of it is now paid Google advertising and not actual search, and information which has been fed to patients by various counselors that they contact, and so it always is a challenge. So coming to these 3 broad procedures which are laser based, and range of corrections available with PRK. I prefer to do a lot of PRK as well, and I'm happy to do it for myopic corrections up to 6 or 7 diopters. I don't like to go beyond 100 microns, but there are centers like LVP which are doing much beyond this and still not reporting significant haze. I do also now correct astigmatism. It seems to work well. So PRK has come a long way with some of the newer thoughts that are there. Smile has been around for many years now, and we've all got excellent results with Smile, and frankly this is the procedure which occupies the biggest chunk of my practice today. And you can correct up to -12 of myopic corrections, including astigmatism up to -5. However, it might be best for myopia between -1, 1.5 to -10. And for higher corrections, Smile tends to offer better stability than LASIK, and of course better biomechanical stability as well. And we all heard about Smile from Sri Ganesh, so I will not delve more on that. And LASIK, of course, remains the gold standard for all procedures. It can almost treat almost everything. And in fact, very small corrections, I would still want to do LASIK. There are patients who come to you with 6/9 vision. They have to qualify for a medical exam. And I would probably not do Smile or PRK for them. Although most people would do PRK for small corrections, I find that the visual outcome and faster recovery with LASIK allows you to get much better outcomes for very small corrections as compared to the other procedures. So PRK pros and cons, I think PRK, of course, we understand no flap, no interface complications, very good biomechanics. I think this is where PRK probably scores the highest, even though we might think Smile is very good, but I still feel PRK has better biomechanics than Smile. Minimally invasive. And then cons, of course, patient discomfort, which has been tackled to a large extent now, and I use AccuVeil or the new product from Entod, which is forgetting the name, but it is similar to AccuVeil, and you can use that for contact lens soaked, and with that, and PRK pain is gone. Risk of haze is very less with appropriate use of mitomycin, but still remains, and you may get surprises once in a while, and slower visual recovery. Smile has already taken place, and Sri Ganesh has already spoken to you on this. So my most important thing with Smile remains that the biomechanical stability is way better because you're leaving behind an intact Bowman's and an anterior stroma, so the strength is much more. Almost no risk of flap complications, almost much less dry eye. And I think most important is quick rehabilitation and almost no precautions for the patient. Post-op, I hardly have anything to tell them. With LASIK, we keep telling them, don't touch like this, don't rub like this, don't sleep like that, don't do this and don't do that. And, patients are usually warned for at least a week or two. In Smile, frankly, on day 1, I don't have much to tell them. And most patients actually do 6/6 on day 1 itself. So minimal precautions. Cons, of course, again, Sri Ganesh has spoken about. Enhancements are now easy to do with Smile. Customized treatments are not possible. And cyclotorsion control only on the newer equipments might become available now. And of course, it's much more expensive. This is where I think the story stops for Smile. Only a few centers can afford it, and very high running costs. So that if that was not the case, I think Smile would be having much bigger numbers almost all over the place. So LASIK, I think full range of treatments possible, faster rehabilitation than PRK and Smile. Query Smile, because now Smile gives me almost equal or even better because patient comfort is much more. And then excellent track record, and customizations and enhancements are easy to perform, and easy access to surgeons because machines are available everywhere. It's been around for so many years and much cheaper to run. But then this is what you may lose sleep over, and they are not uncommon. Once in a while you will come across one of these complications, and I think this is something which, once you start doing Smile, you kind of forget about all these things. Most of these things are not possible. I'll continue with my second talk in the same sitting. I have 2 consecutive ones. So I think, when it comes to the newer diagnostic tools, and that's what I wanted to discuss, I think topography still remains one of the most important, things, and we should not ignore it, even though, Scheimpflug and OCT-based imaging is all available. But a good topography, which is Placido-based, still remains a very, very important tool. And in fact, all the topo-guided treatments that we do are all based on Placido and not on Pentacam-based or other captures. So a good topography is a must. And beyond that, of course, we all understand the importance of pachymetry and how we choose a procedure based on patient's pachymetry. And then the limits of the surgery, we should all understand. PRK, I would not go beyond 100 microns and not leave a bed less than 350 microns at the least, and maybe much more than that. And then for LASIK and Smile, frankly, the criteria remain the same. Although in Smile, you have the additional comfort of a intact cap. So that gives added benefit. And then keratometry, of course, is important because if you're using a microkeratome, you have a very steep cornea or a very flat cornea, and then the range of correction that you might want to do on a very flat cornea may be limited, or on a hyperopic correction of steeper cornea, it may be limited. So always great to look at the keratometry very carefully. And then today I would not operate. I have been using epithelium thickness mapping for last 5-6 years, and I think it's a must for every practice. Of course, if you're starting out, you can bypass this for a couple of years, but gradually you would want to add that. It adds a lot of information, not only in the preoperative workup, but also in the way your patients heal post-operatively. And sometimes when you have unexpected results, you can actually see things on the epithelium which will explain where you went wrong. Picking up suspect corneas also, I think the epithelium mapping is very, very useful. So if you have an inferior steep island and you want to compare that to you'll quickly look at the epithelium maps, and you may be able to pick up why that may be there, and you may pick up a subtle or even advanced keratoconus in a much better way. And some corneas which are showing almost no changes on other investigations may start showing a very little epithelium thinning on the apex and compensatory hypertrophy superiorly, as is evident. Now this is of course an advanced case, but you may see very subtle thinning here by few microns and on the cone, and you may see compensatory hypertrophy around, and that can really tell you if some patients are beginning to develop early keratoconus, and then you might avoid procedures or do a PRK extra kind of a procedure. And then of course when it comes to understanding the post-operative outcomes, epithelium mapping has been very, very useful. You can get very nice ideas of how the epithelium is healing post-LASIK, PRK and Smile, and they vary between the 3 of them, but they help you understand and convince patients if they are getting unexpected visual outcomes. Of course, then warpage case, and this slide is thanks to Dr. Rishi Swarup here for contact lens warpage, and it might look like a keratoconus, but actually it's pretty much the opposite, because you'll see epithelial hypertrophy instead of epithelial thinning on the cone. But on a pentacam, it might look similar. Then the other modality which has really helped us today is abrometry, and eye trace is one of them. There is also the NIDEC OPT scan and a few other abrometers which are available. They've really helped us understand the wavefront, and while you might not use abrometry assisted treatments as much now as you did in the past, but to understand your refractive and cataract bases, this is a very, very useful tool. And it does both a corneal topography and an abrometry, and then puts them together and separates out the lenticular and the corneal wavefront, so it knows what aberrations are coming from the cornea and which are coming from the internal optics of the eye. So it's been very useful. I will not go into the details, but this is one index which I use a lot in my refractive surgery today. There are patients who are in for refractive surgery, and if their dysfunctional lens index is very low, for example, a patient with an absolutely clear crystalline lens would have, say, 10, and in a suspect, you might have like a 7 or 8. But if it is showing something lower than 5 or in the range of 1 or 2, and some of these patients who come in for ICLs with very high refractive errors, they tend to have a very poor dysfunctional lens index. They are not improving to like beyond 618, and you may actually opt for a refractive lens exchange instead of an ICL procedure there, and you can actually predict to the patient if he's likely to get a great outcome. So I have a case to show. I'll just show you that. This was one patient, minus 20 in the right eye with 3.5 cylinder. Left is 5.5 with 1 cylinder, and BCVA in the right was only improving to 636, and patient said, I've always had poor vision in this eye, and obviously with the anisometropia there. And you can see that the Phakic is really small, so this patient is not fit for any kind of laser-based procedure, but has a stable pachymetry over a few years. So we thought this was the epithelium maps, and here we saw that the dysfunctional lens index in one eye, that was the left eye, was 10, whereas the other eye is 1.21. So I'm sure you can now understand the importance. In the eye with the 10, we decided to go with an ICL, and in the fellow eye, which was only 1.21, we knew that patient will not do well. We easily went ahead with a refractive lens exchange, and once the patient was through, patient did extremely well. This was the biometry. Now this is the post-op outcome of the first eye, and not only did the patient achieve an index of 10 after the clear lens extraction, obviously, but also this was a fellow eye, and this patient went on to actually become 6'9" in this eye. So it was, I think that slide is overlying here. I mean, here this patient actually got a 6'9" from 636. So it really helps for us to choose patients. This is only one of the indications that iTrace helps you with, or a good apprometer. So again, age of the patient may decide what procedure you want to offer. And refractive errors you can choose. We've already discussed this. So customization options, you look at the ocular surface, and enhancements are now possible with almost all of them. I will not go into the details, and other speakers are going to cover that. So what has been covered, I'm going to just leave out. For extra procedures, I only limit myself to Smile Extra, which works really well in my hands for suspect corneas, as well as for very high corrections. I use Smile Extra. That gives you that added layer of safety, because even Smile has very rare possibilities of ectasia. And we have access to Aura and Corvus, which have gone. I don't have experience with it, so I'm not going to talk on it, but one of our speakers will. So I think trying to finish off, yes, biometry is one thing which I do for every patient who comes for refractive surgery. It helps you record the axial length, and also various other things, the white to white, and it helps in many ways. So, and also in post-op follow-ups, like 5 years, 10 years down the line, if patient comes with a progression of myopia, you can quickly look at the axial length and tell them if you had a change in axial length, and then they're quite convinced. So a lot of new other diagnostics are available. The MS39, which is spoken about a lot, Bowman's analysis, OCAS, and the confocal microscopy. So there's no end to what we can do, and I'll stop here with a final word. So no one modality is perfect for every situation, and I think understanding each patient's needs by talking to them and understanding their current prescription and everything is critical. And all modalities frankly have a place, and all modalities are actually very good. So we can't call one as better than the other for everything, and we have to choose what's good for a particular situation. And I think Smile has gained in a big way on LASIK, while PRK still holds its own, and Phakic lenses have come in a big way also. And I think once hyperopic Smile becomes available, the indications for LASIK may go further down, which is already quite less. So I think with that I'll stop. Thank you so much. And Rishi, who's going to speak next?
The next speaker, thank you, Gaurav. Those talks are wonderful, and you really covered a large topic very nicely. The next speaker is none other than Dr. D. Ramamurthy, past president of AIOS, one of the leading refractive surgeons in the country. He is the chairman of Eye Foundation Coimbatore, and he will be talking to us about, are all patients suitable for Contura LASIK?
So I think this topic is also really important, because Contura vision has really taken sway, and I know that Dr. Ramamurthy thinks very objectively and can come up with when and when not to choose Contura for patients.
Thank you, Rishi, for that nice introduction, and thank you so much, Gaurav, for including me in this very nice course. I'm going to give you an overview of Contura vision and my indications, and where when exactly and what is the data I use for doing Contura vision. Basically, this is one treatment which worked in the reverse direction, in the sense that it was initially taken up for doing as a repair tool for defective corneas. It was introduced way back in 2003. And where we used to do customized ablation based upon the topographic examination so as to regularize an irregular cornea. Basically, this was the principle of the treatment. You can see over here, this is a flat area, this is a steep area. This is the kind of treatment that is done. To the steep area, you directly ablate, and beyond the flat area, you do the ablation. So that with this bimodal treatment, you end up with a fairly regular cornea and a good improvement in the best corrected visual acuity. What we are looking for in these situations is a best corrected visual acuity. For a long time, we were used to wavefront guided ablations. The optics was what was the buzzword when we started out with LASIK. But basically, topo guided treatment seems to make a lot more sense, because wavefront guided ablation basically flattens out the most steeper area. If your cornea is like this is going to treat only over here and flatten it out. But in the case of the topo guided treatment, it's going to flatten out the steep area as well as the steepen the flat area, so that it becomes like this by doing a peripheral treatment beyond the area of flattening. So because of this bimodal treatment, the amount of tissue that is consumed is much less, and you get a much more regular cornea with this. And that's the reason it was being used for topo guided treatment. Another important advantage of a topo guided treatment over a wavefront guided treatment is that the data that you acquire is what you treat. And because the cornea is static, the kind of aberration profile that you get is reproducible. More of the peripheral data can be taken out. Almost 20,000 points are considered. And most of the aberrations in the eye are based upon the anterior corneal surface, and it is not affected by age, pupil size, lens opacity, etc. And again, this takes into consideration the asphericity of the cornea as well as the curvature of the cornea. And most importantly, the treatment is not centered on the pupil but centered in the visual axis of the corneal vertex. And inherent to this treatment is cyclotorsion compensation and pupil centroid shift, which happens every time the patient shifts from a sitting position to a lying down position. And because of this, obviously, this is a much more physiological treatment to go ahead. So what exactly is the difference between topo guided treatment, what we have been doing for almost 2 decades now, to the recent, not exactly recent, almost a decade now, we have been doing contour vision. Contour vision is essentially the principles of topo guided treatment applied on a so-called normal cornea, where basically it's a run-of-the-mill garden variety refractive error. You go ahead and take care of the refractive error. At the same time, you go ahead and take care of whatever corneal aberrations are there, because of which in the initial FDA study, almost 33% of the patients not just had improvement of the quality of vision, but also the quantity of vision. This was one treatment which gave up ending a better uncorrected visual acuity than the best corrected visual acuity that the patient started out with. So this is the original topographic profile of the patient. This is the ideal topography, and this is the ablation profile that needs to be given. You combine it with the refractive data that you get with the subjective refraction, and that is what you apply on the patient's eye to correct the refractive error. As you can see here, this is basically the manifest refraction that's being corrected. This is the height data that my topolaser gives for correction of the higher order aberrations, and this is the final treatment plan that the patient is subjected to. Usually in the central area is about a few microns of tissue that's taken ahead, and in case there is more of higher order aberrations in the peripheral area, there is steepening or flattening so as to not just take care of the refractive error but also take care of the higher order aberration. That was just the fellow eye of the same patient. Now comes the question as to what exactly is the data that you are going to use as far as the refractive input is concerned. Mind you, your lasers are all mature. Irrespective of the machine that you are using, the physics of lasers is so advanced that they are exactly going to do what they are meant to do. Basically, what are you going to input in this? Most often, what the TCAT FDA study used was the refractive cylinder axis and the magnitude. And in these were cherry-picked such that the topography of these patients, the cylinder, the axis and the amount of cylinder in these cases almost match what was there in subjective cases. But this is a very ideal situation, and in the usual real world situations, 43% of the patient's eye would not satisfy for these criteria. And practically, these might be the patients who have a significant difference between the refractive astigmatism and topographic astigmatism, who might end up with the principles of a treatment with a contourer. So basically the debate comes in as to what exactly is the inputs that you're going to give, whether it's going to be a manifest refraction or is it going to be topographic axis as far as the cylinder is concerned, or you go somewhere in between, which is really not a good way to go. There's no science to it. And then of course 4 CDs came up from Mark Lobanoff, where he basically gives us numbers to the kind of aberrations that are contributing to astigmatism. We tried all of this. We are initially doing all with the manifest refraction. Then because Mark, we tried on the TMR. It did not work too well. 4 CDs is something which we did for quite some time. But now we have come back to manifest refraction axis. It's not just our experience, which I'll be alluding to in the end, but this very significant study where nearly 25,000 eyes in Germany were treated, in Canada were treated, in multiple centers. Retrospectively, we are analyzed between July 2018 and July 2019. 14,000 eyes or so had just a small axis of deviation between the topographic axis and the manifest refraction. But almost 2,000 eyes had a very large angle of deviation, that is more than 45 degrees. But irrespective of the mismatch between the two, they went ahead and treated all the eyes based upon what the subjective refraction came up. And what they found was, irrespective of whether there was a small angle of deviation or a very large angle of deviation, almost 45 degrees, the results were comparable. So the conclusion was that basically the treatment should be on manifest refraction, and we need not exclude such of those eyes where there is a significant discrepancy between the measured and the manifest refraction. Basically, there are 2 different types of astigmatism these patients present with. When it's a small angle of deviation, that is between the measured or the refractive cylinder and the topographic cylinder, it's a larger amount of cylinder that's there. It's 1.2 to 1.6 diopters, and 86% of them had with the rule astigmatism, which is what you expect in the younger individuals. So basically, this was genuine corneal astigmatism that you are treating. On the other hand, when you are talking about very large angle of deviation, it was a smaller cylinder, 0.45 to 0.66, and more often 85% of the patients almost had against the rule astigmatism. So intuitively, this astigmatism that was being picked up on your refraction was not the typical cylindrical astigmatism of refraction, but this is essentially from the posterior surface of the cornea, from the lens, and from the interiors of the eye. So basically what we did was to do a contralateral eye study of 100 patients, 200 eyes. One eye underwent wavefront optimized treatment, one eye underwent contour treatment. The purpose of this study was essentially to compare the two modalities of treatment. But what we found out was 100% of the eyes undergoing contour had a post-operative mean residual spherical equivalent of less than 0.5 diopters. It was in the case of wavefront optimized treatment, which is again an excellent treatment, it was 95%. And more importantly, just like in the FDA study, 30% of the eyes undergoing contour treatment had a one-line improvement in that uncorrected visual acuity compared to the preoperative best corrected visual acuity. Again, we found that contour induced less amount of horizontal coma and trefoil. And mind you, in this particular study, we included all comers irrespective of the variation between the measured and the topographic axis of astigmatism. So this is the way we are doing. This was also published in the Indian Journal of Ophthalmology, and these are multiple presentations, multiple publications that have come about. I know that Kanelopoulos talks about TMR, Lobanoff talks about 4 CDs, but to my mind today, having a significant experience with all these different platforms, irrespective of the kind of variation, we go ahead and plug in the refractive cylinder and the refraction, the subjective refraction that our patients come in with, and then add on to it the higher order aberration profile that we get with a topolizer, and seems to work well. It makes absolute sense to me, because what you correct with your manifest refractive astigmatism is essentially a sum total of anterior corneal astigmatism, posterior corneal astigmatism, internal astigmatism, and what the cortex perceives. Finally, you see with your eyes, but the vision is through the brain. So hence, targeting manifest astigmatism leads to excellent visual outcomes irrespective of the discrepancy in topo and refractive cylinder. So thank you so much for your kind attention.
Thank you so much, sir. It was fantastic as always. We have been also using Faucet's a lot, and I think we've had amazing results with using Faucet's has kind of sorted it out for us much better than we did last few years. I wanted to just ask you that, considering that you also have access to almost all modalities of refractive surgery in your setups, and where would you really want to sacrifice the strength of a PRK or a SMILE for biomechanical stability for LASIK, Contura based LASIK treatment? Like, which are those specific cases? You've already covered all that, but if I had to ask you in like one line or two lines, that where would you really pick, sacrificing the cap or the surface for a flap and the lower biomechanicals, because that would be where it would really be useful. I know it works well for everyone, but since you have access to two other things, what would you choose?
See, PRK I feel is the biomechanically the most friendly treatment. So whenever there is the slightest doubt about the corneal strength, biomechanics, we tend to shift towards PRK. And then SMILE is our primary modality of treatment, but still all of us know that there is no cyclotorsion compensation on this. And whenever there is a significant amount of cylinder that I have to go ahead and treat, beyond 1.5 diopters or 2 diopters, I go ahead and do a contour vision. And in case the patient is very particular, supposing the patient has a fair amount of higher order aberrations, the best corrected visual acuity is in the range of 6 parts or so, I go ahead and again tend to tilt towards contour vision. We do a higher order aberration assessment in all these cases. Where it is significant, we go ahead and do this. And mind you, these are the situations where you would find that your refractive cylinder and your topographic cylinder do not line up. But these are the patients who really benefit from this particular treatment.
I completely agree, and I think you've summed it up really well. Thank you so much, sir. Please, would you join us here? And I'll now introduce our next speaker, Dr. Rishi Swaroop, who's a dear friend, a brilliant cornea surgeon, and does amazing refractive surgery as well. And he's taken on from Hyderabad, and he's taken on a topic which again is very, very important, doing the extra procedures. With all his experience from Shankar Nethralaya and LVP, I think he will be best suited to speak here. Yes, Dr. Subhash?
Recommendation was that if the axis is more than 15 degree, then you go for the wave front optimize and don't go for that contour. So now you are doing contour for all.
That's exactly the perception, in the sense that, in the FDA TCAT study, that was basically the basis of, they cherry pick such cases where the topography and the manifest refraction almost matched. Maybe these are the cases which did not require contour in the first place. Because the reason they matched absolutely was the simple reason that there was not much of higher order aberrations. With a significant amount of internal aberrations, posterior corneal astigmatism, that is when it is not going to match. So you have to take a leap of faith and go ahead and treat these cases based upon your subjective refraction and combine with your higher order aberrations. There was a whole lot of discussion on which one to use, and I find that for the last 3 or 4 years we have been doing this, and this very large study also shows that if you do that, it works quite well.
Thank you, sir.
Hello. Thank you, Dr. Gaurav, for including me in this excellent course, and you can see from the attendance that it's very popular. The topic which has been allotted to me is extra procedures. At the outset, I'd like to say that I don't do too much of extra procedures. I'm a little more conservative when it comes to this particular procedure, but I think I'll probably start doing a little more after I've prepared this talk, because I've managed to read up a lot for it. So why is it extra? Because you're doing something more than your regular corneal refractive surgery. So essentially, when you're saying extra, it means that you're doing a corneal refractive surgery, which may be either a surface ablation or a LASIK or a SMILE, along with a simultaneous collagen cross-linking. And essentially, you're doing this because you have some sort of a borderline cornea. So why do we do it? Because we don't want ectasia. Basically, the bugbear of all corneal refractive surgeries is post-LASIK or post-iatrogenic ectasia, and you want to reduce the risk for that. And hopefully, because you're biomechanically strengthening the cornea along with the weakening that you're doing with your refractive procedure, you're kind of avoiding this risk. So essentially, we use it for borderline corneas, not just topographic, but even otherwise pachymetric or other biomechanical indices. And it is very important to understand that this is not a treatment for ectasia. So if you're thinking that this is early keratoconus, etc., this is a treatment for that, that's not extra. We do topographic guided treatments along with cross-linking, for ectasias as well. But the cross-linking that is done there is different. It's a full fluence cross-linking. This is a partial fluence cross-linking. So we all know about the risk of ectasia, and we know that the LASIK is the one which has the highest risk, followed by SMILE, followed by surface ablation. And several studies have shown these risks, and we've also had case reports of ectasia after SMILE and surface ablation. So no procedure is completely safe from it. This is a very nice risk ectasia scoring system proposed by Bradley Randleman, which kind of told us what are the parameters one must look out for, and kind of give a score. And based on that, you decide whether your patient has a low level or a moderate level and high risk score. People also been looking at the percentage of tissue alteration to avoid the risk of ectasia. So this was a nice paper which came in the IGO from Dr. Sri Ganesh's group, in which they've come up with a very nice simple algorithm to decide which are the patients which possibly could be cases for an extra procedure. So of course, you look at all the parameters that you need to look at preoperatively for any refractive procedure, and if all are absolutely within normal range, please go ahead and do what you normally do. But if you have anything which is borderline, this may be a possible option, other than of course not doing anything or wearing contacts or going for a phakic IOL if suitable. So what they concluded from this review of literature of various extra procedures for both all three, PRK, SMILE and LASIK, was that it's generally safe and effective, which means that it doesn't alter the refractive error too much, and it doesn't cause too many complications. But because most of these studies had very short follow-up, we don't have long-term data. And that's really a very important point, because we know that post-LASIK ectasia can come even years after the procedure. So we probably need long-term studies, and which hopefully should come soon. And then we will be really in a position to say whether these extra procedures really help us or not, or are we just charging our patients more and making it more expensive for them. Also, there's a lot of confusion about which settings to use, what riboflavin to use. So everybody's done their own thing, and that is why it's very difficult to draw any good conclusions from the data. So this was one of the long-term studies from the summary of the different long-term studies for PRK extra, and you can see that the number of eyes is fairly good, 40, 47, 98, 109, etc. But the follow-up, only one study has 25 months, all the others are 1 year or lesser. And what they've shown is essentially the refractive results are quite good, as you can see in that bar. And most of them are within 0.5 of expected results, which is what we want. Corneal haze does happen, but not a very significant haze. So that's something which one must certainly watch out for. LASIK extra, there have been various studies. In fact, this was probably the first extra procedure, especially Tomita et al. Had a very, very large series from Japan. And essentially they've shown equally good results as LASIK, in some cases even better, and they've not had too many complications. So this is one subset which had good efficacy, but safety, again, we need long-term data to see if, because we know post-LASIK ectasia can take time, and LASIK is the weakest of all the refractive procedures. So whether it stands the test of time is something we need to wait and watch. SMILE extra is the newer kid on the block, and some of the bigger data has come from Dr. Sri Ganesh's group from Bangalore, and they again seem to be showing that it seems to be very effective as well as fairly safe. So how is the protocol any different? Basically, when you're doing a PRK extra, it's always better to do a transepithelial ablation, because you can also you could do that, or you could do an alcohol assisted. Transepithelial is preferable. Riboflavin to use, there's a lot of confusion, but most of the people are using riboflavin with HPMC. Some people have also used with saline. Depending on which riboflavin you're using, the soaking time can range from 90 seconds to 15 minutes. UVA irradiation is 30 milliwatts per second for 90 seconds, or 9 milliwatts for 10 minutes. So again, variable depending on different groups have used different things. Mitomycin C, there's a lot of confusion whether one should use or not. There is no clear answer. I don't really think it helps so much to reduce the haze in these cases. In general, the risk of haze is a little higher. LASIK extra, this is what we do. Basically, you create your LASIK flap either with a femtosecond laser or a microkeratome. Then you soak with the riboflavin, which is containing saline, not dextran or HPMC. And this basically soaks the stroma very rapidly. So you just need a few seconds, about 90 seconds of exposure. And then you wash this, and then you kind of put the flap back, and then you essentially do the cross-linking. Now, in the disadvantage of both LASIK and Smile Extra is that you have epithelium on top. And because of that, possibly your penetration of UV may not be as good. Also, the availability of oxygen at the site of cross-linking may not be as good. But again, these are not ectatic eyes. These are normal eyes. You're just giving them a little more. So, you create the flap. Then I told you all this. Basically, again, you use riboflavin saline, and the fluence is variable. Different people have used different things from 1.4 to 5.4. So, from very low fluence to a full fluence. Smile Extra, again, this video I borrowed from Dr. Luthra. You do your routine procedure, and after you remove the lenticule, you essentially put riboflavin containing saline in the interface, and you soak it for about 90 seconds, and then you wash it, and then you do the UV exposure as usual. So, again, here people are using a partial fluence kind of a protocol, which is 3.4 joules per centimeter square. So, the verdict is out there. We don't really know whether it's 100% needed, but it seems to be fairly effective and safe in terms of not altering the refractive outcome and not causing too many complications. What are the cons? You do have a risk of refractive shift, although studies have shown that it's not significant. Haze has been there in all of them, except LASIK has not shown too much of haze. And because of that, you may have a reduced wow effect. Also, because the increased time, patient may not be very happy with it. Also, you're increasing the cost for the patient, which has to be kept in mind at all times. The main drawback, like I mentioned, is the lack of long-term data, and standardization of protocols is something which needs to be done, because everybody has been using different types of riboflavin, different fluence protocols. So we need more data, and I think that this is one place where big data might come to our aid. Thank you.
Thanks, Rishi, for that. Nice. So, touching almost all the extra procedures, and then we have, Shri Ganesh here, who's, specializes in Smile Extra, procedures. And I've been using a lot of Smile Extra as well. And we've also seen occasional haze following Smile Extra, which I think is. So I wanted to ask you about your topical steroid protocol. And Rishi, you for your PRK Extra steroid protocol, do you change it for your procedures? And Shri can tell about Smile Extra.
There are a few things to avoid haze. One is that you need to wash out the dye thoroughly. If after putting in the riboflavin, and the type of riboflavin you use, 0.25% isotonic. So don't use anything else. Otherwise, again, if you use riboflavin with dextran, you'll get severe haze. Mm-hmm. So that's something that you should avoid. Isotonic, 0.25%, soak for about a minute or two, and then the UV at about 3.6 joules. That is one thing. Wash out the dye thoroughly. The second thing is we put them on steroids for about a month, and then later on, if there is any haze, then we change over to fluorometholone and then continue it for maybe another month or two. The third aspect is that you will have to tell your patients to wear UV protection glasses for 3 to 4 months after the extra procedure, because if they go out in strong sunlight, then this also increases the risk of haze. Usually what we see is the haze is mild. We have also, it does not affect visual acuity. We have done the OSIs to see if it worsens the scatter. It worsens scatter slightly, but not very much. So we don't get severe haze. It's not haze that reduces quality of vision or affects visual acuity, but nevertheless you can see it. It is mild, which shows that the procedure is acting. So it's okay. But if you're getting more than that, then probably you need to look at these things.
So which steroid for the first month, and is it different from your usual smile?
Prednisolone acetate.
And for your usual smiles, what do you use?
Prednisolone acetate.
Okay. So, and usually you put them for how many days, like in your normal procedures?
We taper them. Start with 4 times a day, and then 3 to.
No, for your regular smile.
Regular smiles.
Okay.
Even for
Even with Smile Extra,
extra, I
we put
use
the
a-
same
Because we
thing.
use only FML for our smile patients,
Yeah.
and that too for just a week.
no, even for Smile Extra, we do FML only, but we use it for a longer duration than we would do
Okay.
for Smile. And I think if you wash it off thoroughly, I don't necessarily think we have to use Predfort kind of potent steroid drops,
See,
because I have not had a
we
single
looked
case
at
of
see,
his.
we looked at using Lotopred instead of prednisolone,
Yeah.
but somehow the quality of vision immediately after Smile when you use Lotopred is less.
Okay.
Because we had a few steroid responders. These young myopic patients, higher myopes, they are steroid responders, and we have had patients who have come in with steroid response, even early steroid response, and had blurring of vision.
So then
and
why would you use high potency drops for CHL?
because see, what we do is we we call them on the 3rd day and after 1 week now, and check the IOP. Okay, so you have the pre-op baseline IOP. Whatever IOP you check post-op has to be less than pre-op. Suppose pre-op they have a 14 millimeters IOP.
Yeah.
Post-op has to be less than 14. If it is 18, that means there's a steroid response.
Yes.
18 is normal, but don't send them home
True.
because they are getting a steroid immediately kind of shift or stop.
And
the
it's not
steroids.
uncommon to find
It's
steroid
not
response. We
uncommon.
find
the
so many.
argument came
I
up
think every 10,
because
15
So that
you
years
is
I
the
said
think
for
of one.
Smile
Yeah.
Extra
No,
you'll
that's-
use high potent drops. I
That's
said
the
it's not
reason
needed.
why we shifted to Lotopred. But what we saw with Lotoflam is that the quality of vision and the visual recovery is less than if you use Predacetate. So we went back to Predacetate. Patient satisfaction is much better when you use Predacetate in terms of quality of vision, recovery of visual acuity. We have many of our patients having excellent. We just shifted to see if this is so. Now what we do is our protocol is call them early, look for steroid response. If there is a steroid response, then
Then switch them.
immediately we put them on anti-glaucoma medications and kind of. So that's our protocol now.
Perfect. Thanks. And Rishi, quick one on PRK.
So for me, it's the same as the regular PRK, which is
Okay.
slow taper of surface steroids over 3 months.
Great.
Yes.
Yeah.
Great. Thanks. So I think we'll invite our next speaker. Thank you so much for all the other speakers to have put in their comments. And Dr. Chitra Ramamurthy, who's no stranger to any of us. She's a dynamic chairman ARC and a dear friend from Coimbatore who's got amazing repertoire in both refractive surgery and cataract surgery, and of course other things, glaucoma as well. So she's speaking on a very important topic which I thought will really add a lot of value to our surgery. And as I said in the beginning, that refractive lens exchange is now in correct indications, it does give us excellent results, and she'll try to talk about that. Yeah, thanks.
Thank you very much, Gaurav. It's always a prestige to be a part of your course, and the kind of hall being filled up, although it's such in a remote corner, makes me believe that it draws. And I'm going to use this opportunity on the podium to invite you all to my course in the afternoon in the same hall. Those of you interested in refractive surgery will enjoy it. So on to my topic, clear lens extraction now. Is that an option? All along, we did think that clear lens extraction is not an option, and we go double up on ourselves to tell these patients who are erroneously advised by some non-refractive surgeons that clear lens extraction is a bailout for them. But today, I am talking something a little different. So refractive lens exchange, or clear lens exchange as you would call it, is a purpose of treatment not to treat the pathology of the eye, but because this patient wants improved visual acuity, because he believes that the eye ophthalmic surgeons are poised to do A-grade cataract surgery nowadays, and why should he not get visual independence in their late 40s when they could have, why wait till 60 when they get a cataract? So now why this mind change has come in our patient population, where mild hyperope with a presbyopia comes to you and asks for a solution to get rid of glasses. And then there is the other segment of high myopes who are so distressed that they can't do LASIK, and they keep coming back to you. And then you are in a quandary, do you touch these eyes? I wouldn't touch a high myope at the age of 18 or 20 or 30, but I am talking in the presbyopic age group. The why Why is it? Because there is an improvement in the technology as we understand now. The intraocular lens designs are absolutely amazing. The kind of fluidics of the phaco machines which are there are so brilliant. And you know that the cataracts are going to be absolutely soft. You could just use a flip mode and carousel it out. So why not? Today we have ways of correcting the toricity. Today we have a femtocataract platform to treat these, especially this group of eyes, and you can address even small magnitudes of astigmatism with just an arcuate insection. And why would you deny these patients clear lens exchange? So I'm going to discuss these two relevant groups. One, a low ametrope and a presbyo. Now your challenge is, this man wants perfect vision for distance and near. He has a small hyperopic error and he just wants to be free. You have to be very choosy that you choose the right kind of lens. You have to counsel him, understand what he needs. Does he need is great in a distant vision at all times? Does he need trifocality? Does he, and you would not do the two eyes in a very short interval, maybe a week's interval. Check the first eye and do a slow strategy, then choose the other eye, whether you would add a little more myopia, a micro monovision you would do, or would you give him an extended depth of focus? Would you do an extended depth of focus in both eyes? Largely, when you do mix and match, you prefer to use the same material, but sometimes in these eyes you may have to differ based on the need of the patient. And again, a patient with a high refractive error, not corrected by ICL because AC depth is less or too much for an laser vision correction, you have to explain to him there is a loss of accommodation which he is going to find, and you also need to tell him that the architecture of these eyes, whether they are too small or too large, is a huge challenge, and there are challenges in that. So let me discuss case one. Now this is a low hypero. He needs intermediate vision correction. He needs distant near vision correction. But if you have access to eye trace, you understand why this person has come to you. Not all of these presbyopes want a clear lens exchange, but those of them who have a dysfunctional lens syndrome, they do have some amount of loss of contrast or scattering of light, and they are those patients who want a better visual acuity when they are driving. And if you put them on eye trace, you realize that the dysfunctional lens index is less than 5, and that is why he has knocked on your door. And these are those ideal patients for whom you could consider doing a clear lens exchange. If you look at the point spread function, you look at the higher order aberrations, you are there. And you need to be particular that you use an optical biometry if it is possible, whichever brand you use, because we need to do the very best for this group set of patients. If you have access to an IOL Master 700, you understand that there's an advantage of the Swift-Sort OCT and the B-scan combined, wherein you're going to get all the parameters on the anterior cornea, the posterior cornea, and the corneal thickness and the lens thickness. You can never go wrong on the fixation check. You have this telecentric keratometry, and all put together, probably that would be the most ideal platform. And you should use the 4th generation formula and more. Although you would say that you have used the earlier generation formula and you're doing well with your results, but there is absolutely no clear compromise in this clear exchange group. So you need a generation formula where they have lot more variables which are incorporated, as is mentioned there, because the concept is we need to know the effective lens position, and the more minutely these higher generation formulas, later generation formulas go about adding so many variables, like even a lens factor, which is a distance between the iris plane and the principal plane of the lens. So this kind of exactitude in knowing where the lens sits in the bag becomes more important. If you're on the Barrett suit, you have the Barrett Universal 2 formula, which is a mathematical formula, a thick lens formula. But look at it, besides all the other things, it also measures the principal plane of the particular lens. That depends on the geometry of the lens, whether it's a biconvex or a plano-convex or a meniscus lens. It will tell you where the lens will sit in the capsular bag. If it is a Barrett toric, it is not only going to tell you whether it's against the rule or with the rule, but it is also going to tell you the exact measure of the posterior corneal astigmatism. And that brings greater exactitude when you're going to do a toric correction. And if you have the Barrett True K, then it tells you that there is already a difference in the relationship of the anterior and the posterior cornea in these eyes. So it uses the mathematical formula, the double K solution, and it gives you a True K formula. So again, if it is an in excess, you know the Barrett RK formula can be used.
Now let us understand, in 70% of the situations there's no challenge. It is only in 30% of the situations wherein these patients could have a standard deviation which is way off. Then you find they have dry eye, and you treat the dry eye, you realize the values in two modalities are all same, and after that you're done. You could take up these eyes. Again, if it is a post-RK eye or a keratoconus eye or a PMD eye, you can't do a topography. You need to have a machine which has tomography incorporated. You need to understand the posterior corneal astigmatism, and then if you're doing toric, you need to use the right kind of a calculator and use the best formula. Now this was a case of LRCS with trifocal, and he had a small amount of astigmatism in both eyes, and if you have access to the femtocataract platform, you can see that all you have is literally a free floating rhexis, a very gentle hydro, some amount of pneumodissection is done. All you're doing is just separating those nuclear fragments. Imagine there's no stress to the capsular bag, hardly any manipulation, there's no flutter of the iris, the anterior chamber is so stable, and all that you're doing is just picking up these fragments, literally like as if you're cutting on a cheesecake, and the way these comes folding up on themselves. And this is the kind of precision is what this clear exchange patient is going to need. I'm not saying all of us should have a femtocataract, but I'm just trying to show you how you are able to do the surgery with such absolute ease. Believe me, it's barely edited the case. That's how the case does. It is not at all dependent on the surgical skill, and you have to just center the first and the third Purkinje images, ensure it's well centered in the bag, and just firm up the eye. And once you have firmed up the eye, you could go ahead and do your arcuate incision. You could even do your arcuate incision even before you start the case, while the eye is firm and the surgery is done. And look, this is the kind of result this patient will have, one after the other and in all situations, and they're going to be happy. The case 2 is a high myo. Now this guy has a -14 and odd cylinder, and again, there's nothing for him to do a laser vision correction or an ICL. You have to evaluate the posterior segment carefully. You have to tell him a guarded visual prognosis. Chances of RD is there, but he had a PVD, which was again played to your advantage. And you need to do a B scan, look at the posterior staphyloma. If it's a posterior staphyloma, you would rather do an optical biometry. You want the refractive axial length. You would look at the latest formula, a Barrett Universal Hill RBF or a Van-Cox modification. You have to be critical as to what you choose. Now in a long eye, what you need to understand, you're using a low powered IOL. So low powered IOL, the refractive surprise is not going to be much, and the ELP will not be impacted with the visual outcome, and you get done. But in the surgery, what are the challenges? What you need to understand is it's a deep AC, difficulty in manipulating your instruments. You might end up thinking the eye looks big, so you think it's a small rhexis, end up with a larger rhexis. You would have a myopic shift. You don't want that. You would do a good amount of hydrodelamination, which makes it easier to remove the soft cataract. You would not remove the instrument because the iris can go and get stuck on the lens surface. You could have a reverse pupillary block. Then you have to tap the iris up from the anterior lens surface. You have to always ensure that the infusion is on or viscoelastic is injected so that there is no pressure difference between the anterior and the posterior chamber. And most importantly, you should ensure that you remove the viscoelastic. Steroid responder has to be kept in mind. You avoid anterior lens polishing if it is a toric IOL. And also if it is a very large eye, you may want to use a CTR if you think there could be a toric IOL rotation because it's a very large capsular bag. These are the things which you have to consider. The other challenge in a high myopic eye, this a high powered small eye, is that it is a different kind of a scenario, high powered IOLs. So even a small mistake in your refractive calculation, there'll be a big refractive change. And again, another challenge in a very small eye is that the anterior chamber could be very small, the axial length could be small, vice versa. It will not be an ideal situation. So you need to use the best formulas. You would have to use customized IOLs if it is a very large IOL part. The challenge is you could have increased spherical aberrations in these eyes. Then you might even consider putting the bulk of the IOL part in the capsular bag and using a piggyback IOL for sulcus placement and get yourself bailed out of those kind of movements. So these are the things, the pearls which I've told you, you have to consider and reconsider. You have to do a thorough examination right from the ocular surface, the refraction to the tear film, to all parameters of the tear film, to everything. Is there an early PCO? You would address that. You would prefer an optical biometry. You should look at the raw data. Believe me, do not let your technician do that. Is there an asymmetry in these eyes? Is there an amblyopia in these eyes? Should you have explained something more? Is there a difference in the axial length? Should you calculate again? You need to treat the astigmatism. Finally, you should plan whether you would give a high ad in one eye, low ad in one eye. Would you do an extended depth of focus? Would you give a trifocal IOL? So what I would like to tell you is choose the right patient, a very driven patient. Explain all the conditions to him. Do a perfect surgery, but with those selective eyes. And when the patient is closer to a cataract surgery, but has just a dysfunctional lens syndrome, I think I would choose these eyes for a refractive lens exchange, because these are the patients who are keen on a refractive cataract surgery. Thank you very much.
Thank you so much, ma'am. Again, very nicely covered emphatic presentation with a lot of conviction. Thank you so much. We do have no one less than Dr. Sonu Goyal, who's a brilliant phakic lens surgeon, and we have just 5 minutes left to the course. He'll try to do justice in these 5 minutes, and Sonu, I won't waste more of your time. Thank you so much.
Thank you, Gaurav, for making me a part of this course, and I'm sure in another 5 minutes that have been allotted to me, I'll make you all refractive surgeons in peanuts. I think what you have heard from all these master blaster surgeons, they drive Ferraris and they are millionaires. But yes, we poor ICL surgeons, and that is what I want, that you all presentees here can start your refractive practice from the moment you reach back to your town. So I think ICL has been a great game changer in the refractive practice, and you need nothing. You as cataract surgeons, you have all the armamentarium that is required for a safe refractive practice. So just skipping 5 minutes I have. So we all know that these phakic IOLs have been a part of the spectrum of the refractive surgery. They have shifted from the angle supported to the posterior chamber. And the beautiful concept of the posterior chamber basically allows to the lens to sit right in the nodal point, giving you a very stable location. And gone are those days where you have a lot of uveitis, secondary glaucomas and stuff like this, and they are easy to remove. So reversibility is one of the key factors with these posterior chamber phakic IOLs. We all know the right candidates as refractive surgeons: age, refractive stability, and the corneal considerations to be taken when you are assessing the patient for the phakic lenses. And the key important factors in deciding is the sizing of the ICL. So the sizing basically depends upon the two key factors: the ACD. The ACD is basically the endothelium. A lot of people have a lot of confusion in this, and as per the US FDA it is 3, but for the Indian consideration we are taking 2.8, and it is the endothelium. So this is one key factor where as refractive surgeons you should never ever compromise on the anterior chamber depth measurements. Different equipments have different calibrations, but what we use is the pentacam, which we believe is the gold standard for measuring the anterior chamber depth. And white to white we use the digital calipers, though you can whenever you in doubt you can take the readings from different equipments, the IL Masters or the pentacams, but what makes me feel best is the white to white on the digital calipers. So what I have been given is ICL in low myopia, and believe me, ICL, whether the refractive error is low, moderate or high, it works equally well. And the indications could be the refractive, LASIK rejects, and there are certain off-label indications to be used after refractive surgery where you have those patients with refractive surprises, patients with the post-penetrating keratoplasties, ICRs, patients post cross-linking, and sometimes you have those pseudophakic surprises. The basic concern we as refractive surgeons would always have: what is the efficacy in low diopters? Predictability. Is it safe? And what about the low cylinders? Because normally as a nomogram, less than a diopter, we would always take just the spherical correction. So yes, here is the gameplay where when you're doing a LASIK or a PRK or a SMILE, you're addressing cylinders as low as 0.25 diopters, which you are leaving untreated when you're doing an ICL surgery. So this beautiful article published in the JCRS comparing the 2-year visual outcome head-to-head between the ICLs and the small incision lenticular extraction, that is SMILE, for diopters less than -3. This beautiful paper, takes care of all your doubts. So efficacy, if you compare the post-operative efficacy indices, which is basically post-operative uncorrected divided by the pre-operative of the ICL and the SMILE group, were all comparable. The safety indices, again, the post-operative corrected divided by the pre-operative of the ICL and the SMILE group were quite comparable. And when you talk about the endothelial cell density, there was no statistical significant difference in the endothelial cell count before and after surgery. So this is a small study for over a 2-year period. So ICL stands safe in low diopters as well. And when you talk about the predictability, you see here the spherical equivalent of all eyes in both the groups, the ICL and the SMILE group, were all comparable. Yes, a small point here, the residual astigmatism was within 0.25 diopters in 80% of the ICL eyes, comparable to almost 100% of the SMILE eyes, where they were able to correct the cylinders to almost near normal. Now, this is one very important point. Just 30 seconds to conclude. So, HOAs and specifically the vertical coma in the SMILE group were increased after surgery. So, both the ICL and the SMILE, they lead to a significant increase in the post-operative HOA, but when you compare both, SMILE leads to a slight more induction of vertical HOA. Again, this beautiful paper in the American Journal from the Chinese group mentioned the increase in the 3rd order, 4th order and the total HOA after ICL implantation were significantly less. So to conclude, ICL is comparable, it's safe, efficacious, and gives you a long-term visual stability. So you have that EVO advantage. You leave the cornea virgin, there is no thinning, there is no risk of ectasia, the refractive stability, and there is no regression. It is minimally invasive. There is an immediate recovery, so there is a very short recovery time. It's predictable, induces less higher order aberrations. And what is more important, when you compare head to head, it gives you a slight better contrast sensitivity as compared to any refractive on the cornea platform. It's reversible. And the last and important, what we all share, is the investment-free approach with these phakic IOLs. So thank you so very much, and all to Dr. Chitra.
Thank you very much. I think we should not be holding the next session, and Dr. Purendra Bhasin is not going to be happy. But thanks a lot for being with us. I do hope you're going back with some of those traces of doubts which may be there in your mind, and we are always there to answer any of your doubts at any point of time during the conference and beyond. Thank you very much. Thank you.
So all to Dr. Purendra Bhasin, please. Thank you.
Thanks a lot, Dr. Sonu.
Thank you.